will post very soon, model documentation for this updated version 3 model, and that includes your technical discussion, underlying data, references to parameter values, and the literature from which they come, and then for the not so faint of heart, the equations that govern the transitions of population through COVID-19 states. We also anticipate posting the programming code this afternoon at 5 p.m. On a software collaboration site to which I've posted a link here. So why the need for updated models and new models? Most of you know this and have heard me say this, and others at a number of times. The COVID-19 pandemic remains in its early stages. It's been 3 months in Minnesota. It's been 4 or 5 months across the globe. It's a new disease with evidence emerging virtually daily. Models ultimately serve the purpose of providing understanding of the shape of the disease, the likely way it's playing out in a population, and in order to present that abstraction of the real world in the most real way or most accurate way possible, we need to feed to it the knowledge that we have about the disease. And as that changes, the inputs have to change. And sometimes, as we've done in version 3, the structure has to change to accommodate sort of a new understanding of how people experience the disease differentially. So the updates take into account our growing understanding of transmission and outcomes. They incorporate new data from the US and Minnesota, replacing some of the evidence that had earlier emerged from China. There are a number of factors why the Chinese data may not be as predictive of the US, including that mitigation was very different from what we're experiencing here, and that the treatment or healthcare services looks different than it does in the US. So using US data will be more representative for Minnesota, we think. We're refining the projections by fitting the model to observe data on mortality and hospitalizations, and then add new capabilities to the model that I'll walk you through in a second. There's been a great interest in sort of the data that informs the model, and I think it's a legitimate interest. But I think it's also really important to understand what we know and what we don't know, and what we sort of need just better information on over the next months or so. I'm repeating myself, I know, but it's an important point. The epidemic and the evidence still is very new. There is still a great amount of uncertainty about the impact of key metrics. We don't know. We know now that there are a significant number of asymptomatic patients, but we don't know what role they play in disease transmission, other than that they do play a role. So we don't understand why jurisdictions have different experiences with the disease. We don't understand the healthcare challenges that individuals experience, what are driving them, at least not specifically. So the data is only as good as the evidence that has emerged in practice, and the model is only as good as the evidence that we feed into it. So there just needs to be more better evidence emerging. Clinical protocols have been changing. I think we've heard that in the context of ventilation, but I think that will also emerge in the context of treating patients at different age groups and identifying all the symptoms that indicate COVID-19. And to repeat this point a third time, the data that we have available is limited. And here are a few examples of what that means. So 2 key studies that everyone is using in their modeling lack outcomes for about half of the cases in those studies. So in one study, for 2,000 cases, we just don't know the outcomes. And we don't know whether the missing outcomes biases the analysis or not. So that just needs to play itself out in the literature and maybe also in practice. The same is true for a second study from the New York City area, where about close to 6,000 patients were hospitalized. We don't know the discharge or um, mortality status for 46% of the population. Some of that is just bad data, focusing maybe on treatment and not on collection of data, which of course makes sense. But some of that also has to do with the fact that the disease hasn't resolved itself for many of these patients. And on this last point, that's also true for Minnesotans infected by the disease. A few days ago, the statistics comes from a few days ago, about 32% remain in hospitals. So we have an incomplete understanding about the duration of the disease and whether it differs in Minnesota, and how much resources patients need when they are um, um, very ill from COVID, from the pathogen. So here are 5 key changes that were made to the model that I want to tell you about. Number one, there are a couple of structural changes in how the model accommodates individuals sort of moving through different compartments from exposure, from being susceptible to being exposed to becoming infected to recovering, to requiring hospitalization to recovering. So we have built pathways for asymptomatic patients to move through recovery without requiring hospital care. The data is incomplete, but we know that is happening. We want to make sure that we don't overestimate the need for hospital care by routing them directly to recovery. We also understand that not everyone who succumbs to the disease has required hospital care or has asked for hospital care. So we need to make sure that deaths in the model can occur outside of hospital settings, whether they're in nursing homes or at home. We've restricted the ICU metric to only ventilated cases because that is what clinicians tell us what matters. We've updated parameter estimates to some US data, and then we've made a number of new calibration to parameters to make sure that the model reflects as closely as possible the real world, still remembering that it's an abstraction of the real world in the way that we can represent it through mathematical equations. So one of those calibrations accounts for the fact that a proportion of elderly individuals 70 years or older are dying outside of hospital settings. So that's important to, again, not overestimate healthcare demand. And then secondly, we in the model recognize that the mitigation strategies in place in Minnesota, social distancing and stay-at-home order, were not as effective as we assumed. So we are building those into the model to present more of an accurate reflection of the kind of transmission that has been going on and will continue to go on. And then ultimately, we're also fitting the model again to Minnesota deaths and hospitalizations, in this case, through April 25. And I'll pause here to ask Dr. Hens to walk you through the model fit graphs that I'm showing you here on cumulative deaths and hospitalizations, particularly with an emphasis to how the model deals with infections from hotspots such as food processing plants or long-term care facilities or other congregate settings. Eva, can you take a second?
Sure. Yeah, thanks. So here what we're showing you is for our base case parameter set, the model output, those are the black dots against MDH surveillance data. So what we did was essentially looked for sets of parameter values among these uncertain parameters that generate model outputs that are consistent with what we've observed thus far. And so we looked at both fitting to cumulative numbers of deaths in the state as well as the number of prevalent hospitalizations, which includes both patients who are in the hospital, and those who are in the ICU or require mechanical ventilation. So by doing this, this gives us a sense of what are the kinds of model parameter input values that can reproduce what we're seeing in the state. And as Stefan mentioned, we do calibrate a number of different parameters, including kind of the contact reduction associated with the current stay-at-home order, and the proportion of elderly individuals who are dying at home, as well as kind of adjusting data that we have on the need for hospitalization among people who are infected and the proportion of asymptomatic infections. So all those parameters together, there are a number of different combinations that can fit these data. And so that's where we're taking our uncertainty from which is not represented here, but that's what we're taking our uncertainty from in this round of the modeling. And then our base case kind of reflects a sort of median value among those kind of input parameters that fit these trends well. And so you can see how it's fitting against the data. The cumulative deaths are increasing, and certainly, some of that, a lot of that is being driven by deaths in congregate care facilities and people being exposed who are particularly vulnerable to mortality. So we are fitting to that, though the model itself can't readily accommodate issues of the clustering that occurs in congregate care facilities. So it is still an approximation of that. One mitigating factor that we have is that we are allowing deaths to occur outside of hospital settings, and so many of those deaths that to fit that cumulative death curve is through this kind of out of hospital death. So we're able to also fit the hospital demand with that data. But the hotspot issue is a limitation of this kind of model. This is really about projecting trends overall, and so harder to get at the clustering that can occur in congregate care facilities.
Thanks, Eva. So moving on slide 11, what are the impacts of the structural changes, the new data, the model calibration, and the model fit? Generally on the outputs, generally what we are seeing is there's less time to peak epidemic, and there's some upward movement in our estimates for ICU demand and full epidemic mortality. And what seems to be driving that, there are essentially three factors that interact to produce these outcomes. Number one, as the deaths rise and as we calibrate to rising deaths, our mortality increases. Number two, as we find that there's more mixing going on in the population than we had assumed, more individuals, the diseases spread farther, and the potential for individuals becoming infected and requiring hospital and ICU care increases, and therefore mortality increases. And I'll pick up that point up in a second again. And then thirdly, as we estimate that ICU mortality, as the US data shows us, ICU mortality appears to be increasing relative to our early estimate. That drives some of the change, but also we're setting the probability of mortality to 100% for individuals who are unable to obtain mechanical ventilation, and that's what clinicians tell us. If there is a patient that absolutely requires mechanical ventilation and they can't get it, they will die. So that is what we're taking into account in this model. So a word on mitigation. You may recall that we assumed for the initial physical distancing period that it would reduce contacts by about 50%, and for the stay-at-home order, a reduction of contacts by 80%. As we're sort of going through the process that Eva described in calibration, we're realizing we have more infection than this assumption in contact reduction accommodates. So what we're realizing, the actual and most likely reduction in contact is lower than what we had assumed. 38% instead of 50% for the initial physical distancing period, and 60%, about 60%, not 80%, the stay-at-home order, and we're taking those mitigation effects into the scenario from here on, realizing that that those are more reality-based than our initial assumption. Um, they are possible. They'll, they it is possible for these mitigation effects to change further, depending on how the population interacts with response to good weather, or sort of how compliance varies over time as the summer and the spring wear on. So we wanted to show you a one-to-one comparison between version 2 and version 3. The point here is not to dwell on this, because this is really in the past. Scenario 4 assumed stay-at-home order till early May. We have moved past that, but had we modeled scenario 4 on version 3, what would the outcomes have looked like? Or rather, as we modeled version 4, scenario 4 in version 3, how does this compare to results that we produced with version 2? So 16 weeks under version 2, sorry, 13 weeks instead of 16 weeks, so shorter time till peak. Not much change in ICU or ventilator demand, a modest increase in mortality, and certainly one that is within the bounds of uncertainty under model 3. And then we added, and we'll do that throughout, a mortality through the end of May to address some confusion that we've heard. Some folks have been looking at these numbers and have said, look, you estimate a peak in June or July, and then there are 20,000 deaths, but we only have 500 deaths or 540 deaths now. How does that work? So what we wanted to clarify, the mortality is cumulative mortality for the duration of the pandemic, which we model to in a window of about 12 months. But the near-term mortality would be, of course, much lower. So as you're ramping up to the peak, mortality would be increasing, but not to 29,000, to a much lower value, and mortality would continue to occur as we're moving down from a peak.
Stefan, can I add one thing about the differences? If you can just go back to that slide.
I have.
Version 2 versus version 3. Yeah, perfect. So one point that I do want to make is that we've changed how we're reporting the max ICU demand. So prior in version 2, that number reflects kind of what was coming out of the model, and where we hadn't modeled such an absolute mortality outcome for people who didn't receive ICU care when they needed it. In version 3, what we realized is that because we have mortality set so high that essentially within a day, someone who does not receive care that they need would then die. The max ICU demand kind of outputted by the model plateaus essentially at your capacity, because those who exceed capacity don't survive to continue to demand that care. So what we've done now is we now run those numbers with an infinite ICU capacity in the model. And so this number is in fact the kind of true number of people demanding ICU capacity. So if you wanted everyone who predicted by the model who would need, in this case, we're referring now to ventilators, then this is the number of ventilators that you would want at that peak demand point. So it's also a difference in the reporting of the model, and I just want to point that out, especially because we are releasing the code later today, and so that's an important consideration if anyone's trying to run or use the code, that that number is generated in a slightly different way.
Thanks, Eva, for the clarification. And,
sure.
and if there are more questions about that, maybe we can take them offline, because it's a technically complex set of facts that I think we're sharing with you with regard to that metric. So I'm going to show you a couple of slides now on new scenarios available that we modeled on top of that uh, version 3 model chassis. So two things have taken place. We created a new chassis, so to speak, and then we also created a new set of scenarios for consideration by state leaders and the public and individuals such as yourself. I'm anticipating the question, why did we choose these scenarios? Who asked us to model these scenarios? The answer really is that the way I would answer that question is to say, is to remind us again what the model is about. Why are we modeling in the first place? And the modeling serves really an educational purpose for state leaders and for the general public to tell us about the likely outcome of the disease given a set of assumptions about disease dynamics, incubation, infection, periods, transmission dynamics, etc. So the purpose of this is to educate us collectively and say, here's what could happen under a set of assumptions and a range of interventions by policymakers. These are not recommendations. These also don't reflect um, questions or directions from policymakers on what we should model. They reflect a mix between capabilities of the model and responses to questions that we've had in the past around, uh, why is there no flattening, for example, or some considerations that are actively going on right now about what's the impact of testing, or what if we had a treatment available. That is what these scenarios are about. They still are hypothetical in the sense that they reflect a curve up to an intervention that is assumed to end. If interventions don't end or they take a different shape to generate a different outcome, that model would have to build them in to produce those outcomes. So I hope that's good background information. So without further ado, there are three scenarios we're modeling here. One again is the no medication scenario on top of version 3, and then scenario 5 is assuming the stay-at-home order goes through the May 18th and is then followed by sort of a soft release with a reduction in contacts around 38% for 3 weeks and ongoing recommendation for staying at home for people most vulnerable, and in this case, primarily elderly. And then scenario 6 takes that that hypothetical scenario and pushes it out through 531, pushes out the stay-at-home order through 531. And then what you see is what you would expect, I think, since you've been uh, um, uh, good students of our work to date. With the stay-at-home order through 518, we see a drop off the peak and a shift to the right. This is about buying more time, as we've said. And scenario 6 would continue this trend. The impact, sort of mechanically, would be moving from, under the no medication scenario, we would be in the midst of the peak epidemic, moving that to June, to the end of June, or in scenario 6 to the beginning of July. Ventilator demand would fall to around 3,000 under scenario 5 and 6, and mortality to about 29 or 28,000 for the full pandemic. Mortality through May, the model anticipates around 1,400 or so individuals in scenario 5 and 6. Again, you may ask, how is that possible given that we are currently at below 600 cases due to COVID, cases, individuals dying due to COVID? Is that possible? We hope these are pessimistic estimates, but it's certainly a plausible outcome with the assumption of continued increased spread and wider spread among the population. Moving on to testing. So I want to be clear about these testing scenarios to say these continue to be hypothetical in a number of ways. So I think we're in a process of developing protocols that make it clear who should be tested, um, uh, um, where, how many tests should be available to really make sure the population understands that, as well as healthcare providers. And once these protocols are really clear and fully understood, I think we can update our test scenarios. But the testing scenarios are um, are complex and hypothetical at this point. They're complex because they assume they're kind of layered, and I'll walk you through that right now. Um, they're layered in the sense that we have two, a best and a worst test scenario. Under the worst testing scenario, we have low sensitivity in uh, in the tests, and we understand its sensitivity ranges somewhere between 70 and 90%. We have low sensitivity under one scenario and 95% sensitivity under a different scenario. In the worst case scenario, we also assume that only 10,000 tests are available, while in the best case scenario, 20,000 tests are available. And to complicate the matter further, we layer these best and worst case scenarios on top of scenario 5, where we assume stay-at-home order ends on 5/18, and scenario 6, where the stay-at-home order ends, is expected or is assumed to end at the end of May. We can provide more one-to-one comparisons to any of you who are interested in that. The point of um, uh, this presentation is just to show you the range of plausible scenarios, I think. So green is our index here, scenario 6. Red is stay-at-home order goes to May 18, and then on top we have some testing available as shown in the middle column, and then purple is the best case testing scenario in the right column. What changes? Under the best case testing scenario, we are seeing more time available till the peak materializes. We're seeing lower demand, and we're seeing also lower mortality, and modestly lower mortality through May. I want to say one more thing about these testing scenarios. What we're modeling here, and it's limited to the structure of the model that we have available, what we're modeling here is only the response to testing to the individual who has received a test, and not to his or her network that who might have been exposed and infected from that um, one individual. Sort of the point of contact tracing is, of course, to interrupt not just the continued transmission by one individual, but to identify the possibility of infection among individuals this one person has come into contact with. It's just not easy to do in the model, or possible to do in the model. So we hope to develop a more realistic simulation of testing scenarios outside of the model to tell us, here's the real benefit of effective and high quality testing in Minnesota on mortality and on healthcare demand. So that's work that still needs to continue. But you see essentially the impact of testing downward and shifting it out to the right. Maybe that's not much of a surprise. The third slide and the last two scenarios I want to show you are is in response to question we've had in the past, where people have said, since we have been talking about the epidemic, we've been talking about flattening, but all this model seems to produce is a shifting of the epidemic to the right. So I think we've said this before, and I think some models have documented this as well, either intentionally or unintentionally. The real pathway to flattening, significant flattening on the curve, is long-standing mitigation. I want to be clear to say this is not a recommendation from the research team. There's not a recommendation from this work. Decision makers are considering trade-offs between the epidemic and other factors. But if we're looking for flattening of the curve, something like the CDC scenario for opening up would have to come into play. Under this scenario, the CDC suggests that states may not wish to open up until they see a downward trajectory of cases, or as we model it, hospitalization for at least 14 days following peak infection. To accommodate that, you would have to have some form of mitigation, like a stay-at-home order that reaches into September. Again, that is maybe entirely undesirable and not worth the trade-off. But if flattening is what we're looking for, that is one of the tools that are available to us. What we did in addition to that hypothetical scenario is build in the question of the impact of treatment. Folks are, of course, very interested in saying, what if a treatment is available, whether it's an antiviral drug or other treatments? How does that affect the outcome of the disease? There's a lot of research going on, not a lot of evidence. The only evidence that has materialized over the last few days, and I want to applaud our research team to jump into that and pull it into the model, is from the clinical studies of remdesivir that the FDA has approved, I think, for treatment of hospitalized cases, patients with a complex expression of the disease, very ill patients. And what the initial data seems to be showing is a reduction in the length of stay and a potential reduction in mortality. So that's what the team built into it, and that's what you see reflected in the pink curve, in contrast to the blue curve above it. So again, it's hypothetical, and if treatment become available before then, we will make every effort within the limitations of our capacity to illustrate that to state leaders and the public as we're doing it in here. I want to make one concluding thought on this slide that is worth to consider. Again, don't take that as a recommendation. Just take that as a set of lessons from the disease dynamic as we observe it. If we're looking for a treatment like remdesivir to be available in sufficient doses to treat patients, perhaps beyond those who are hospitalized, but also with those who would be affected and who are at home in isolation, for that to be effective, I think we want to possibly avoid a peak. If treatment becomes available after a peak, then the benefit of this treatment will accrue to a smaller part of the population. It's not wasted, it's not useless, but I think the impact will be smaller, and that's something that state leaders, I'm sure, are taking into consideration. I believe I have 2 more slides, and I'll wrap up quickly. This is just to show you the daily death and reiterate the point I made earlier. The pandemic, the mortality attributable to the full course of the pandemic is what we're showing you, in addition to a May estimate. This shows you sort of what that looks like in the context of the peak under different scenarios, peaking at below 2,000 cases in the no mitigation scenario, and peaking at levels below 750 or so under different scenarios. So it's important to recognize that even with that relatively lower peak, it is entirely plausible, and the model produces mortality that is pretty dramatic in the context of any other history that we have for mortality related to a single factor, whether it's traffic deaths, whether it's cancer, whether it's military conflicts. So I want to close by peeking into the future and saying we will be looking for more and better data from the US epidemic and from Minnesota. We're looking to both refine and enhance our work. The refinement most likely will take into consideration treatment to the extent that it has been authorized for in-home treatment. So rather than just looking for individuals who have indicated who receive treatment in the hospital compartment or in the in the hospital or ICU compartment in the model, we could move it up into the infectious state and similar to testing, as I said, to look at the impact of contact tracing. Been a lot of talk about why the model seems to be producing a single curve when it's either desirable or even possible to imagine multiple curves um, over the period of the pandemic, um, be it through different mitigation effects, be it through cycling of mitigation, be it through the possibility of the virus changing in terms of its um, degree of transmission. Um, this model has been based entirely on scientific evidence. So we have decided not to model hypothetical scenarios that we don't have underlying data for. So as that evidence emerges, we can build that in and draw you a cycling of curves as others have done. But for the moment, we don't think that's a good use of our time and your attention. And I'll close by just showing you that there's a large team behind this work, and as well as a number of anonymous reviewers who've looked at the programming code and provided feedback on the underlying methodology. The parameters are available as well, and here's sort of a visual representation of the changes to the underlying structure of the model to accommodate, as I said, mortality outside of the hospital care and the evidence of asymptomatic patients, asymptomatic individuals who hold the infection. So I'll pause there and look forward to answering your questions.
It looks like, so reminder to, if you have a question, please indicate in chat that you have a question and we'll call on people in order. Looks like David Montgomery has a question to ask. David, feel free to unmute yourself.
Yes, can you hear me?
Yes,
go ahead, David.
Great. Looking over the sample curves that you showed us, I was struck that most of the curves seem to show relatively moderate impacts on peak ICU usage from various different scenarios, except for the CDC opening scenario, which you mentioned would involve a stay-at-home until September. Is it accurate to say that these models are showing that, you know, an extra week or month of stay-at-home doesn't actually have much of an impact on the peak ICU usage? Or could you explain more about why the only dramatic difference in the curves are the ones that have stay-at-home going into the fall?
Yeah, I'll start it off, but then I think Dr. Enns has some thoughts as well. You know, through going back to version 1, what we have been saying is the most effect from our mitigation strategy is to push out the curve to the right with some impact on full epidemic mortality as well. So I think that continues to be the case. The question is, what are we doing with that extra time? And that is where the testing scenario and the treatment scenarios come into play. So just buying time without using it will not dramatically change the outcome of the disease, because once mitigation drops, there are considerable number of individuals in Minnesota still susceptible to the disease. And once the pathogen starts circulating as population mixes, I think the outcome based on people's individual probability to be hospitalized and require ICU is generally unchanged. But Eva, how might you add to this?
Yeah, no, I think that's right. If you're a week or two here and there, is going to shift that peak, and it's about using that time. And then if you go into longer periods of time, you do see that peak reduce further. And it is about basically changing the situation so that when you do resume some kind of activity and higher levels of contact, that the situation is different. You're better able to care for people. You have more capacity to care for people. You're better able to identify infection and isolate infected individuals and their contacts. And perhaps you're also better able to continue some level of social distancing. So in many of these scenarios, we have kind of a soft opening and then continued reductions in contact for vulnerable populations. But you could imagine using that time to also set up kind of policies and structures in workplaces and places of business that allow some level of continued reduction that's more sustainable and not as extreme as a stay-at-home order, but allows us to continue to slow spread and have these lower peaks as well.
And just to
So
clarify,
it really is about using that time. It really is about using the time.
And just to clarify as a follow-up, other than the scenario 8 with the treatment option, none of these curves are reflecting the use that Minnesota might make of that time.
In some ways, the testing scenarios do, because the testing is kind of implemented at the lifting. I believe it's May 18th is when testing kind of comes into play there. And on those scenarios, the reason that we've put that kind of worst and best case scenario with of testing with scenario 5 versus scenario 6 is some notion that if you had some additional time, you could ramp up your testing capacity more effectively. So to be kind of ready for more extensive testing if you had more time. But yeah, it's a tricky thing to kind of know how these things will ramp up and what exactly the targets are.
Hi, this is Commissioner Malcolm. I just wanted to hop in on this point, just to reinforce something that I think the researchers have said since the beginning, that this is intended to illustrate really broadly directional trends and changes, and it's very tempting when it looks this tidy to draw conclusions about specific points in time or specific degrees of change, but that's really not how the model is intended to be used. I think it's intended to illustrate kind of relative effects. And I appreciate the charts with the confidence intervals around them as an example, which just reminds us of how much the scenario.
Yeah, and I wanted to add to the Commissioner's point by saying, what for this briefing, we have, for simplicity's sake, not illustrated the uncertainties around each individual curve, but we'll make this available and make it clear to everyone that that there is a range around each estimate, both over time and with regard to the absolute value of the peak. The other point that I wanted to make in response to your question, David, about time is maybe a little meta, but I think it's an important one. So we're showing you scenarios based on the evidence that currently is shared among experts at the CDC, and our colleagues across the country and in Europe. I've said this before, there's a lot of science going on every day that will change our understanding of underlying factors. So for example, treatment protocols are beginning to change. Protocols with regard to ventilation are beginning to change. And as we're learning from those, we can incorporate the different understanding about probability of mortality, the need for ICU demand into the model. Some of those changes might be marginal, some of them might be not. So time buys us not just, time doesn't just buy us the ability to do things differently, but it also buys us time to get a more accurate understanding of what the disease turns out to be like and inform state leaders and the public about that. So time is our friend in many ways.
Next, we have a question from Adam Uren. Adam, if you can unmute yourself.
Hello, can you hear me?
Yes.
Yeah.
Yeah, hi. So just regarding the end of May figures, the presentation currently predicts a range of 1,400 to 1,700 deaths by the end of May in Minnesota. To reach that, you'd have to see between 40 and 56 deaths per day on average. And currently, there's not been a single day with more than 30. So are you saying that we can expect deaths to increase significantly in the coming weeks? And if the deaths don't reach that figure, which I hope it doesn't, does that not render your model significantly flawed?
Yeah, I'll start kicking that off, but I think Eva will have a few things to say about the potential of a flawed model as well. So I think, again, taking a step back and reminding you of three things. The purpose of the model is showing general directions, right? The general direction that we're seeing here is that there's increased mortality and by the end of May, and that it is not 26,000 as some folks have worried about, interpreting the full pandemic mortality as a point-in-time mortality. I think secondly is there's a range uncertainty around this point, and I think it goes from about 1,000 to about 2,000 cases. So these are plausible outcomes of the model, right? Thirdly, I would say I share the hope with you that we're wrong and this is a pessimistic outcome of the model. Nevertheless, I think it is a plausible outcome based on what we understand about the rate of transmission of the disease, the rate of contacts, the rate of mortality in the population as is, and sort of generally the disease dynamic or the disease kinetics. Eva, how would you add to it?
Yes, I think it's important that, we're using the information that we've observed so far, the trends that we've observed so far, to estimate the parameters in the model. And then the model itself is set up to kind of mechanistically represent how diseases spread through a population. And it is absolutely an approximation of reality. And so that's a disclaimer of any of these kinds of models, but it's a way that we can kind of take the general trends in how we know diseases spread between people, which is through contact between susceptible and infected individuals, and the general kind of progression parameters and needs for hospital care and mortality that we've observed thus far, and extrapolating that with the information we have. As we observe deaths further, then we can recalibrate and kind of regenerate our estimates. So that's all a part of the process. It's really saying if we have to make a best guess right now, if we need to make decisions right now, what can this model tell us today, with the understanding that if we're looking again in 2 weeks, that we'd want to reassess that model. So I think fundamentally flawed is strong. And it's really about making decisions under uncertainty with the current information at hand.
Just a follow-up, if I may. Does the model that you put together take, we've seen most of the deaths so far have been happening in long-term care settings, and does the model take into account the measures that the governor and the health commissioner have announced in terms of taking a more aggressive approach to limiting spread within long-term care?
So currently, we do have kind of a mortality component that occurs outside of hospitalizations, which is kind of making up much in mortality that's occurring in long-term care settings. We have not currently implemented any kind of additional or say reductions in contact among older individuals and vulnerable individuals who would be those people who would be protected by long-term care changes. So that's not something that we've put in the model. We do have continued kind of protections in place for them after under these different scenarios, after kind of more general policies are lifted. But that is something we could model if we add information to kind of guide how effective those are in terms of the contact reductions in kind of a general population estimate.
Okay, so depending on the speed at which the administration works with long-term care, this data could be out of date very quickly.
Hi, this is Commissioner Malcolm. I think it's a great question, and that's certainly our what we're working on now is to implement that plan. So I think if I'm understanding what Dr. Enns is saying, that the model doesn't assume any impacts on mortality itself. It just is built around contacts among people in different risk categories. So it's a good example, I think, of something that in future iterations of the model, we may be able to provide some more updated information to model in. But again, that could be an example of something that the model's never really going to be able to be refined enough to pick up all of those effects about interventions.
Okay, thank you.
Stefan, Commissioner Malcolm, it's 11:58. I want to be respectful of your time. I don't know if we have time for one more question or if we should end there. If you have any final thoughts.
Yeah, no, we can continue for a few more minutes. I think I know there are a lot of questions still in queue, and certainly we will answer them offline and be available to reporters for the rest of the day. But I think we got time for a couple more.
Great. Jennifer, looks like you're next in our queue.
Yeah, thanks for taking my question. I have a question about the testing numbers. So say I get tested and I come back negative, but my symptoms get worse and I come back and I get tested again. Are these testing numbers counted as single tests, or does it count those who have been tested more than once?
Eva, do you want to?
In terms of how we've implemented it in the model, someone could get tested more than once, kind of on a probabilistic basis. So some proportion of people are being tested. So to the extent they're kind of remaining in those states, we don't take negative and remove them from being tested again. So that's how we've implemented it in the model in terms of testing numbers and estimates that are coming out of the state or that capacity. I would defer to Commissioner.
So I think it's certainly the presumption that people will need to be tested on more than once, particularly in the expanded long-term care testing that we're going to be doing, and as well as in hotspots and vulnerable populations. Just understanding that a PCR test is at one point in time that doesn't definitively answer anything about whether the person has been exposed and may be developing infection, at a later point in time, or even during the course of the current exposure, that they just may not be symptomatic yet, which is why we focus on suggesting that the priority is testing for symptomatic folks. But so that the need to test more than once factors into our goals for why we think it's important to eventually get up to 20,000 tests per day or beyond, so that we've got that capacity for that repeated testing where it's indicated. But in terms of how that plays into the model, I deferred certainly to the researchers on whether that could or would make a difference in the model results.
Yeah, sort of by definition, the scenarios are capped at 10 and 20,000. So to the extent that there are multiple tests done for individuals, that is sort of the environment in which the scenarios have been are playing out.
Jeremy Olson, looks like you're next in the queue.
Yes, hi. Take me through this a little bit. I think I understand, but I just want to make sure. You had just said that buying time is what you do with the time that is makes a difference, and yet I'm seeing by buying time in some of these different scenarios that the number of deaths, estimated number of deaths, go down. Why is that? Are you predicting increases in hospital capacity or other efforts that are producing that? If not, I don't understand why the deaths would go down if we're just pushing out the peak. Why would those numbers be going down?
Eva, do you want to take a first crack at it? And
Sure.
Jeremy, is your question with regard to a specific sort of scenario?
No, I mean all of the scenarios show that basically a later stay-at-home order, the deaths would go down. But you just said that time doesn't bias anything. So why are these deaths going down? Is there something in the modeling predicting changes in our medical capacity or something else?
Yeah, so that's a good question, and it relates depending on what the comparison is. The differences are different. Actually, Stefan, maybe going to the unmitigated is just the previous slide there. Yeah, so the unmitigated again was if we had done nothing, and that was with our original state ICU capacity that was kind of estimated in March of 235 beds. And so then the difference between the blue curve and the red and all subsequent curves is one, an expansion ICU capacity. And that was kind of one of the first changes and priorities that was made right in the state policy or state response. And so that's driving mortality reductions there. I will also say, the longer these social distancing stay-at-home orders are in place, there is some flattening. Again, if we go to the extreme of CDC policy and do it for months and months and months, then we see that flattening more dramatically. But it does reduce peak ICU demand, and thus the mortality associated with exceeding ICU demand across the board. So it is true, the longer you do it, you get these marginal differences. I think it's when you're looking at a scenario where you're extending stay at home for, 1 more week or 2 more weeks, that the marginal differences don't seem that dramatic. But if you're comparing no stay at home versus stay at home for 6 weeks, then you'll see larger differences. The other thing that's happening with the testing scenarios is then we're assuming that there's some testing going on, that there's more identification of positive cases and isolation. And so there you have a reduced number, fewer people are getting infected is the upshot. And so if you can prevent infection, then you can prevent the downstream mortality risk associated with that infection. So that's what's happening in, say, scenario 6 versus scenario 6B, right? So that's a difference in testing added onto it. So it's a little complicated, and it depends on which pairwise scenarios you're making the comparison between.
But to answer the question, Jeremy, that you asked, there is no further, we have not assumed that ventilator demand would change or that hospital capacity would in some other ways vary.
And quick definition question, the line on the charts that says top ICU/vent demand, is that days, is that people? I just want to make sure I understand the number right.
Sure, that's people. So it's like a prevalent, the total number of people simultaneously needing ICU ventilator care at the same time.
Gotcha. And do these forecasts then show us having any days of that absolute death scenario of people not having vents when they need them, or have you modeled that? Yeah.
So the way, again, I think the clarification I tried to make on during the presentation of having that infinite ICU capacity is coming into play here. So that top ICU vent demand is assuming that particular row of numbers is run, setting the model to have infinite ICU capacity so that we can see the total number of people who would kind of accumulate into the ICU if we had no limitation on that at all. And so that's where we're getting that 3,000 or 2,400 number from. So that's if you wanted to fully accommodate the full ICU demand over the course of this scenario of this epidemic, then that would be kind of the capacity you want to plan for. In terms of all the other numbers, including in particular the mortality number, that's run with ICU capacity at the cap that we have set right now, which is 2,200 beds. And so that mortality accounts for exceeding ICU capacity.
Gotcha. Sorry if I missed that in the presentation. That helps. Thank you.
No worries. No, it's a good clarification. An important clarification and a point that I think might be confusing. So important to be clear about.
And we are, I think, a little bit over time now. So let's just take one more question with apologies to those who are still in queue, but please follow up with us directly. So last question, please.
Tim Nelson.